The next lecture will be given by Dr. Susan Blazer, neuroradiologist at the Hospital for Sick Children, Professor of Medical Imaging, University of Toronto, Toronto, Canada. Her topic is congenital abnormalities of the skull base.
I'm delighted to have been asked to share my cases of congenital abnormalities of the skull base with you. I'd like to thank and acknowledge our colleagues in the divisions of neuroradiology, craniofacial surgery, ENT, neurosurgery, and genetics, the fellows, the CT and MRI technologists, and the electronic imaging team. We have no conflicts of interest to report. Learning objectives are to know what imaging options are available to assess the skull base, to review developmental stages of skull base and chondral bone formation, to identify normal skull base anatomy, including the bones, the boundaries, the synchondroses, and the foramina, and to identify common and syndromic skull base anomalies, including midline and off-midline defects, synostoses involving the skull base, and foraminal stenoses. The imaging options in ascending utility are going to be radiographs, which are still ordered, 3D photogrammatic analysis, as here, in which you can assess a single suture by measuring the cranial index, the anterior skull volume, and the symmetry ratio. Here's pre and post-op for sagittal synostosis. MRI, ultrasound, and ultra-low-dose CT, the latter of which is going to be the most important for us. Ultrasound can assess suture patency in single suture synostosis. Here is a normal view with a hypoechoic and bevel gap of at least 0.5 millimeters. Here is Apert's with a wide suture, and here happens to be a few suture. Note the double line going all the way across. There is no gap. Unfortunately, it does not address the skull base. Black bone 3D MRI is not yet as robust as CT, but software packaging is improving. The top row is MR and the bottom row is CT. If you take a look at the MR, you can see that you do see a unilateral coronal synostosis, although you do see the suture a bit better on CT. The results are quite variable. In this particular case, for example, of unilateral lambdoid synostosis, you really can't see either suture very well, and yet you can certainly see the normal lambdoid on CT. Again, so skull base is not assessed on these. Fetal black bone and 3D skin surface MRI is possible. Skin surface phenotyping can be done with a FIST 3D data set. It is very time consuming. It still requires a very calm fetus. The black bone source imaging is present here, is used by just susceptibility weighted imaging, a pull down sequence, but we can't do 3D. It's not robust yet. If you take a look at this one, here's a fetal 3D or fetal single shot fast echo showing pterionic ridging here. Here it is as well, and here you can see that there is definition of the actual bone, although it's really hard to see the actual sutures. Now here you can see that fetal black bone is gestational age dependent, and note the comparison between CT, single shot fast echo T2, and susceptibility weighted imaging in this 22-week fetus. You can see the bone and cartilage here, although it's not definable as separate entities. And here you can see bone where it's particularly dense. It certainly is not as dense as you would see on CT, and not as dense as the prior case, which was 33 weeks gestation. Ultra low dose 20 to 30 MAS postnatal CT is very useful. We use a ultra low dose, which only requires 0.02 millisieverts, which is equivalent to a chest X-ray. A head CT with brain imaging at our institution is 1.7 millisieverts, and background near sea level is going to be 1.8. Published low-dose CT at 120 MAS is not low dose. Let's start with skull base embryology. Molecular and cellular factors direct a complicated developmental process that includes cellular creation and growth, pre-placodal specification, apoptosis, migration, differentiation, and fusion to get from here to here. Ossification centers are well underway by 10 weeks of age. We are just going to be looking at enchondral bone formation, so anything in here that's green. And if you take a look here at the supraoccipital bone, half of that is going to be actually membranous and half of it's going to be enchondral. We will exclude the frontal bone plates because they are going to be membranous, and everything here is going to be enchondral. So this, this, and this. Enchondral bone formation will provide the remainder of the skull base. The sphenoid is essentially the backbone of the skull base, and we can see here at 18 weeks gestation and at 20 weeks the greater wing of sphenoid and the lesser wing of sphenoid. We'll use the Gruber version of pre-chordal cartilage development, in which the pre-sphenoid provides the anterior sphenoid body. The basi-sphenoid contains the cellulosic and posterior sphenoid body. The orbitosphenoid is the lesser wing of the sphenoid bone and the planum sphenoidale, and the alisphenoid is the greater wing of the sphenoid bone. The next developmental stage will be suture and synchondrosis fusion. Calvarial bones arise in ossification centers around 2 months gestational age, and spicules of bone grow towards each other. Sutures form at the site of meeting bone fronts, and sutural fate is determined by the underlying regionally differentiated dura mater. Interdigitating figures of bone project into the sutures, and the osteoblastic and clastic activity contribute to fusion activity. I want you to note the FGR expression on the leading bone edges here and here, and remember this because that's going to be important in some of the syndromes we see later on. Chondrification and ossification ensues in the skull base, where unossified cartilage will eventually simulate bony defects during early life. So here at 20 weeks of gestational age, you see a lot of defects. In fact, except for the foramina, which you can't really define so well here, all of that is cartilage. It's not just floating bone. Here by 28 weeks and 31 weeks gestational, you can see that those are filling in. This area of here, this defect here, is called the olivary eminence, and this is the postsphenoidal cleft. These areas rapidly fill in with growth of the ossification centers, and you can see here, all the way out to here, the fovea ethmoidalis and the central features are going to deepen as you have progressive fusion, and the skull base foramina are going to become more discrete. So taking a look here and taking a look here. And chondral base foramina are mesoderm derived, following a specific pattern of development as is seen here. First, dense mesenchymal surround is going to rarefy, and that's going to happen prior to the development of the perichondrium. That's the blue line here. So let's take a look at how that happens. Well, SOX9 is a chondrogenic fate specification pathway gene, and it is expressed in that foraminal mesenchyme. So here again, foraminal mesenchyme surrounding the jugular vein in a chick. Here, the sparsely distributed foraminal mesenchyme and the well-defined perichondrium, which occurs after SOX9 is switched off over time, leading to a zone of chondrogenic inhibition. The optic foramina are junction foramina formed between the basi-sphenoidal cartilage, which is neural crest, and the basi-postsphenoidal cartilage. Here you can see the optic canal here and here in the chiasmatic grooves. That defect here is just from the chiasm. The cribriform plate foramina are examples of a neural-dural interface. Layers of this neurodural transition traversing the foramina are the subarachnoid space, the arachnoid membrane, the dura mater, the periosteum, the ethmoid bone, the submucosa, and the mucosa and epithelium. Cribriform ossification is not actually identified until late infancy. So here, let's take a look at the stage 22, 52 post-fertilization day specimen, and you can see here are the olfactory bulbs. If you take a look at where those will be setting, it's right here, and here, and here, and here. You can see the cribriform plate is certainly not ossified at 1 day of age, but by 10 months of age it is. These little spicules will start at 3 months of age. Here's a hypoplastic cribriform plate in a child who lacks olfactory nerves and bulbs. So if you take a look here, you can sort of see the actual cristagalli, but you don't see much of cribriform plate, and in fact, that never does develop. Similar findings may be seen in Kallmann syndrome, again, 1 day old and 10 months old. Note that midline structures fuse when not impeded by intervening structures or by edge cell failure, sometimes by both. Here is an example of midline fusion failure in a 31-week fetus. It's due to interposed and actually unsuspected sphenoidal encephalocele in a fetus who happens to have callosal agenesis. Here is that large defect here and here. Another example, this one with frontal nasal dysplasia, shows a very large defect here and here. It's not the same child. And you can see that there is central incisor separation, mild hypertelorism, but there's a very large basal encephalocele. Facial features in frontonasal dysplasia do not always predict defect size. So here's a very wide defect rather than a narrow anterior skull base. There is the usual skull base involvement, but here is a relatively smaller persistent craniopharyngeal canal. Now, why would you have so much widening here? Well, some of these mutations cause sonic hedgehog excess, and a sonic hedgehog is what we used for ventral induction. Persistent craniopharyngeal canals can also be seen in many other disorders, including the trisomies, the hypomyelinating disorders, some frontal nasal dysplasia, charge, morning glory syndrome, and SOX3 mutations. And so therefore you need to remember, because these all can have vascular abnormalities, remember to check the vascular channels and foramina. So this is a child with charge, and you can see there is a diffuse ICA stenosis, as well as a narrowing of the intracranial vasculature as well. But when you take a look, you can see there's congenital hypoplasia of the horizontal petrous carotid canal, reflecting this particular stenosis. But in fact, this is due to the fact that this was a small vessel, and we have ossification surrounding that small vessel. Other clival defects are going to include the fossa navicularis magna, also known as canalis basilaris, here and here. You can have small asymmetric clival channels, which can be oblique, and basi-occipital clefts and defects. This is a lovely article with a picture showing what the notochord pathway is, going up here, and it can traverse, and you can have channels all along that, and here is the region of that fossa navicularis magna. Clival channels may also form around other vascular structures and plexi, and may provide potential path for intracranial ingress of pharyngeal infections. So here's an article showing what these small vessel or channels look like, and if you gave contrast, you might be able to see a venous plexus in some of those. Here happens to be one of our specimens from our own lab, and you can see in this late third trimester fetal specimen that you have multiple small channels. Again, they can be oblique, they can be parallel, they can certainly be vertical or horizontal. Basi-occipital defects or basi-oticum defects are transverse basi-occipital clefts, which may be unilateral, bilateral, or complete. Here is what they look like in a specimen. Here is what a unilateral one looks like, and here is what a bilateral one looks like, also in a child who has a cleft basion. Bilateral are usually syndromic and commonly charged. Not always, though. Here's a child who was imaged for congenital sensory and neurohearing loss. He certainly has semicircular canals, does not have CHD7 mutation, but there is a very large cleft traversing, and it's communicating all the way across, communicating across his clivus. An absent clivus and basisphenoid are really, really uncommon, but they do occur. Here happens to be a skull-base deficiency here, and there's also a duplicated cerebellum, so this is likely a rhombomer mutation. Let's look at some normally formed foramina, such as the foraminal valley, and these are three different imaging techniques of the same particular region. They may become enlarged or eroded, even if they start out normal in size. They can have enlarging lateral sphenoidal encephaloceles. It can be pressure-related. They can have NF1-related sphenoid dysplasias. Here happens to be a child with transalar sphenoid encephalocele through foramen ovale, which is quite large at this point. And this child had Lehmann lateral meningocele syndrome with the Notch3 mutation. Foramina may also become stenosed, for example, in Cruzon, and remember FGFR2. This is an FGFR2 mutation. The venous complications may predate surgery. Here we have two different children. In the first, we see a jugular foramen stenosis, and in the second one, we see extensive venous collaterals because of their jugular venous stenosis, which is already occluded. They may also become unusually positioned. So here we have kissing carotids due to early transverse synchondrosis fusion in another Cruzon FGFR patient. So let's remind ourselves of anatomy before reviewing the synostoses involving the skull base and start peripherally. Here are the mastoid and the pyramidal portions of petrous bone, and here is basisphenoid. And now centrally, the occipital bone is comprised of 6 bones. All but the squamous portion are contiguous with foramen magnum. Here's the basion, which is the midpoint of the anterior margin of foramen magnum. It belongs to the basi-occipital bone. And here are paired ex-occipital bones, and the ventral chondral, and the posterior squamous, remember, is portions of the supraoccipital bone. Finally, the opistheon, which is the midpoint of the posterior margin of foramen magnum, which develops from Kirkring's ossicle. A reminder, the ventral chondral and the posterior squamous portions of the supraoccipital bone are ventral and posterior to the mendozal sutures. Let's go on to the synchondroses. The occipital bone has 6 pairs, and they are named by adjacent bones, essentially. The petroccipital, therefore, is between the petrous portion of the temporal bone and the basi-occipital bone. The spheno-occipital between the sphenoidal body and the basal portion of occipital bone. Kirkring's ossicle and petromastoid are named as expected The last two, which are probably the most important for us, are named differently. The anterior intraoccipital between the basi-occipital and the exoccipital bone and the posterior intraoccipital are called by their name. The intraoccipital because they remain inside the occipital bone. This may also be called the innominate suture. Let's start peripherally. Here are the mastoid of the posterolateral fontanelles, the site of the asterion, which is the junction of the parietomastoid, occipitomastoid, and lambdoid sutures. Here is the parietomastoid synchondroses. Here are the occipitomastoid synchondroses. Here is the lambdoid suture. Here are the anterior intraoccipital synchondroses centrally, the petrooccipital synchondroses, the spheno-occipital synchondrosis, and the posterior intraoccipital synchondroses, which are also known as the basicranial synchondroses and the innominate sutures. Finally, Kirk-Ring's ossicle or Kirk-Ring center is the last of the occipital centers to undergo ossification. It appears as a chondral center at about 16 weeks gestational age and fuses with the supraoccipital portion of the occipital bone in the first month or so. It's relatively variable. It forms the posterior margin or arc of the foramen magnum. That is called the opistheon, this particular region here. The intraoccipital synchondroses should be assessed according to age-matched controls with every study. There are definite time intervals at which they should be closing, and you will see that the anterior intraoccipital synchondroses here and here always fuse later than the posterior intraoccipital synchondroses. Panfusion of the intraoccipital synchondroses can lead to coarctation of the foramen magnum. So here's a normal foramen magnum in an 11-day-old anterior and posterior intraoccipital synchondroses. Those are your posterolateral fontanelles right there. If you take a look at this 7-day-old who has cleavage shuttle, you can see that the synchondroses are closed. Again, they are pointing to the foramen magnum and they are encased within the occipital bone itself. Here in X-linked chondrodysplasia punctata, you have fusion of those synchondroses as well as hypertrophy of the inferior occipital crest. Absent ossification of Kirk-Ring's ossicle leads to absent bony opistheon. There is cartilage there just is no ossification. This happens to be a median cerebellar suture, and this preteen has cleidocranial dysostosis. The median cerebellar suture is extremely rare, so if you happen to see one in a skull base that doesn't look abnormal, this is probably going to be a true fracture. Now, there are only two synostosis subsets that involve the skull base. The first is going to be the lambdoid suture, and it involves, here you can see the enchondral portion of the supraoccipital bone, and it's the least likely to be treated or imaged. Note the ipsilateral mastoid bump, which is the typical finding on plain film and on your 3D CT here and here. Unilateral lambdoid synostosis differs from skew malformation, and the way it does that is that you have, in lambdoid synostosis, contralateral frontal bossing, and in positional plagiocephaly, you have ipsilateral frontal bossing, a trapezoid configuration if you drew lines all the way across, and here parallelogram. And note the additional fusion of the posterior intraoccipital synchondrosis here. Now, bilateral lambdoid synostosis is rare. It leads to a flat occiput. It can be seen in the progressive stenoses. Here again is the additional posterior intraoccipital synchondrosis fusion. Mesenchymal holes or thinning confirm surgical fusion in this 4-month-old with extensive Apert syndrome, but it's on its way to cleavage shuttle. Before we go to the coronal synostoses, let's go back to anatomy. Here are the coronal and the squamosal, the lambdoid sutures. Here is the posterolateral fontanelle again. Here's the zygomatical frontal, frontosphenoidal, and the spheno-squamosal sutures. And here is asterion. Imaging in the unilateral coronal synostosis, and you'll see this later on in Callie's talk, is going to have a progressive plagiocephaly with angling of the sagittal suture. There is a nasal tilt due to the involved nasomaxillary suture, and there is contralateral forehead bulging and a harlequin eye. The nasal tilt always points to the unilateral coronal synostosis. It's more than just coronal synostosis, however. Here is an obliterated coronal suture, but there is also a narrowed squamosal suture and a small greater wing of the sphenoid. Here is a nearly obliterated sphenoparietal and sphenofrontal sutures. With coronal synostosis, the hemiring in unicoronal or the entire coronal ring in bicoronal is involved. The coronal ring and hemiring separates the frontal and the sphenoidal bones and classically includes the contiguous frontoparietal, frontosphenoidal, and frontoethmoidal sutures, and also includes sphenoesquamosal and sphenoparietal sutures. Here is the frontosphenoidal synchondrosis, 31 weeks and 39 weeks. Here it is right here, and here it is here. You can see that this one is relatively small, and this one is on its way to fusion. The harlequin eye is the typical ocular finding in the craniosynostosis. Additional findings would be exorbitism, hypertrophy, strabismus, and malfunctioning or abnormal oblique muscles, because they would be up here. While winking orbits are seen with the frontosphenoidal fusion. And remember, the frontosphenoidal synchondrosis is part of the hemiring. Here is isolated frontosphenoidal fusion. So here happens to be that winking orbit instead of harlequin. And you can see here that there is frontosphenoidal synchondrosis. And here is the unfused side. Here is syndromic frontosphenoidal fusion in a Cruzon patient here at 2 days of age, 38 weeks of age. You can take 38 weeks gestational. You can see that there is a relative harlequin eye, which alters as long as there has been progression of the hemiring fusion. Here, taking a look here, that's not a very straight line. Here you have coarctation of the foramen magnum already at 2 days of age. Additionally, early sphenoidal occipital synchondrosis fusion in the syndromic bicoronal synchondroses can contribute to decreased AP skull base growth as here, progressive mid-face protrusion, take a look here and here, and an angling of the skull base. Take a look here. So here's a normal 7-year-old. Here is a child that happens to have Apert syndrome, and as this has fused, you can see it is now quite verticalized. Here, this child with Aperts is looking very similar to the normally developing child at 7 years of age. So in summary, we have reviewed the skull base development and anatomy, the midline and off-midline deficiencies, clefts, the foraminal stenoses, and the craniosynostosis involving the skull base. And I would like to remind you at this point to go and always review the arterial foramina and venous anatomy at the same time in these children. Thank you very much for your attention.
The next lecture will be given by Dr. Caroline Robson, Division Chief of Neuroradiology, Director of Head and Neck Imaging, Boston Children's Hospital, Associate Professor of Radiology, Harvard Medical School. Her topic is congenital craniofacial disorders.
Hi, everyone. I'm Kelly Robson, and I'm a pediatric neuroradiologist from Boston Children's Hospital. I'd like to thank our wonderful ASHNR Program Chair and President-elect, Ilona Schmalfuss, for the invitation to speak today, and all of you, our audience, for joining us for the virtual ASHNR annual meeting. I have no relevant disclosures to make. In this talk, we will briefly review craniofacial embryology, discuss an imaging approach to craniofacial disorders, and then review 4 major topics: micrognathia, cleft lip and palate, small or absent nose, and craniosynostosis. The development of the human skull and face is a highly orchestrated, complex, 3-dimensional morphogenetic process that involves hundreds of genes that control coordinated cell growth, migration, differentiation, proliferation, and apoptosis. Craniofacial malformations arising from abnormal development comprise over 1/3 of congenital birth defects. To briefly overview development, the first pharyngeal arch gives rise to the paired maxillary and mandibular prominences. The maxillary prominences fuse with the frontonasal prominence, as seen here, to form the maxilla and upper lip. The primary palate derives from the maxillary processes and the frontonasal processes, and the secondary palate, posterior to the incisor foramen, derives from maxilla and palatine bones. Importantly, neural crest has a major contribution to craniofacial development, and there are a number of molecular, mechanical, and morphological steps involving the fusion of contributing structures, including a key epithelial to mesenchymal transition. Failure or interruption of any component of craniofacial development leads to regional or localized craniofacial defects. There are a wide range of modalities available for imaging of craniofacial disorders. Ultrasound is used for fetal imaging and to assess cranial sutures, notably the sagittal sutures, but we rely heavily on low-dose CT and 3D models to depict craniofacial anomalies. MR is excellent for fetal imaging, and more recently black bone techniques have emerged for the assessment of craniosynostosis. Although articles have been around for the last decade, more recently these articles have highlighted the utilization of black bone MRI for the assessment of craniosynostosis. The advantages of these techniques are that MR avoids ionizing radiation. However, the disadvantages are that patients are more likely to require sedation or anesthesia. There is a greater likelihood of image degradation due to motion in awake patients. MR is more costly, and a significant amount of time is required for accurate segmentation in order to provide these 3D models. However, more recently, automated segmentation techniques are gaining acceptance. Lastly, these 3D MRI techniques are less reliable in very young infants in whom the bone is thinner and in patients with very prominent convolutional impressions where there are focal areas of thinning. Moving on to micrognathia. Micrognathia is fairly frequently encountered and is often associated with underlying chromosomal abnormalities and a myriad of possible genetic mutations. There are some features that help the radiologist in determining the differential diagnosis. For example, is micrognathia bilateral or unilateral, symmetric or asymmetric? Are there other anomalies affecting the branchial apparatus, temporal bones, orbits, or other organ systems such as spine, kidneys, and heart? This is an example of Treacher Collins syndrome, which is one of the typical examples that comes to mind when thinking of bilateral, relatively symmetric micrognathia. The clinician taking a look at the patient should arrive at this diagnosis pretty readily because of phenotypic characteristics such as down-slanting palpable fissures, very pronounced posteriorly slanted and downward slanted malar eminences which are too small, micrognathia, and ear anomalies, microtia or anotia. The genetic underpinnings of Treacher Collins syndrome have been well established, and there are various types with variable inheritance. Now let's look at an example. Bilateral micrognathia, down-slanting palpable fissures, the rather posteriorly slanted malar eminences, microtia, the small mandible has a very obtuse angle over here, and there's deficiency of the condyle. Notice also this defect in the zygomatic arch, very characteristic of Treacher Collins syndrome. Treacher Collins syndrome is associated with severe anomalies affecting the external and middle ear spaces and contents. Typically atresia of the external canals, the middle ear space is small and often opacified. The ossicles are rudimentary or absent. This patient also has colobomata. In this example, there are posteriorly slanted malar eminences, severe temporal bone anomalies, also in this patient with an inner ear anomaly, small semicircular canal bone island. If surgery has to be performed for any reason, be aware of landmines within the middle ear space, such as oval window atresia with malpositioning of the facial nerve canal. Soft tissue windows show reasonable muscles of mastication, but often a degree of absence or hypoplasia of the parotid tissue. A similar syndrome is Naegger syndrome, much less common. Be aware of the potential for airway obstruction due to micrognathia. Again, temporal bone anomalies, and in this condition, radioulnar synostosis. Now, when it comes to bilateral, asymmetric, or typically unilateral conditions, the hallmark of a more unilateral micrognathia is hemifacial macrosomia. This is a group of conditions which are of uncertain etiology. Few genetic mutations have been described, but most of uncertain etiology. Small mandible, absent condyle, deficient zygomatic arch, a degree of mid-face hypoplasia, smaller orbit, and in golden heart phenotype, epibulbar lipodermoids, and vertebral fusion anomalies. Temporal bone imaging in these patients shows atresia or stenosis of the external canal with associated middle ear and ossicular anomaly, rotation of the spheno-squamosal suture out of the usual sagittal to a horizontal orientation, very typical, and small muscles of mastication and anomalies of the parotid, big accessory parotid but lack of parotid in this location. On the affected side, once again, oval window atresia, an anomalous tympanic facial nerve canal running across the floor of the middle ear space, poor mastoid pneumatization, and low dura of the middle cranial fossa, all surgical landmines. And so to summarize, unilateral micrognathia, think hemifacial macrosomia, symmetric micrognathia, most commonly due to Treacher Collins syndrome, both of these with characteristic ear anomalies, asymmetric bilateral micrognathia to varying degrees with branchio-otorenal syndrome. Look for associated branchial apparatus anomalies, tags, pits, sinus tracts, fistulae, and anomalous large eustachian tube, and these kids also have characteristic inner ear anomalies that are beyond the scope of this discussion. Now, when you hear terminology such as Robin sequence or Pierre-Robin sequence, this is not a syndrome. This is a descriptive terminology for a group of patients who have micrognathia, which causes the tongue to be displaced upwards and backwards, and this prevents normal apposition of the palatal shelves, resulting in a U-shaped cleft of the secondary palate, and this in turn causes respiratory obstruction and postnatal feeding difficulty. This descriptive phenomenon is seen in a variety of syndromes, including Treacher Collins syndrome, but also Stickler syndrome, which is a collagen vascular disorder, and 22q11 deletion syndrome, otherwise known as velocardiofacial syndrome, as shown here, in which there are characteristic temporal bone anomalies. There is a thickened stapes and a horizontal semicircular canal malformation. So, cleft lip and palate. Now, about a third of cases are syndromic, and interestingly, as you look at these clinical pictures, this is the most common type of cleft, which is off midline in location, and this is the least common type of cleft, which is a true median cleft. The whole premaxillary segment is missing. And the interesting phenomenon is the more cutaneous involvement and unilateral lesions, such as unilateral cleft lip in isolation, are least likely to be associated with syndromes, and the worse the abnormality, then ranging to bilateral cleft lip and palate, is more likely to be associated with an underlying syndrome, as is this true rare median cleft lip and palate. And there are a huge number of associated syndromes. We use the Vaux classification, a descriptive classification from 1931, to describe the various patterns of involvement of soft palate, hard palate, alveolar margin unilateral or bilateral. And more recently, this article by Dr. Alorian, Malikan and co-authors suggested that we should rather be using descriptive terminology incorporating the Vaux classification to describe cleft lip and palate. How does that translate for the radiologist? For the radiologist, then, we have to describe which side is involved, whether it is unilateral or bilateral, and then describe the severity. Are the margins separated? This is a complete cleft, or are the margins opposed, an incomplete cleft? And finally, move on to anatomical involvement, cleft lip, alveolus palate, and incorporate an assessment of the Vaux classification in terms of additional involvement of the hard and soft palate. Here is the normal palate and upper lip on fetal MR. The normal palate is U-shaped and is well seen as outlined by amniotic fluid. This is an example of a midline or median cleft lip and palate. The premaxillary segment is completely absent. The nose appears flattened or absent. Postnatally, this patient was found to have lobar holoprosencephaly, and there is the wide cleft with deviated nasal septum. It is said that the face predicts the brain for holoprosencephaly. These are abnormalities affecting the orbits and eyes and nose, as well as dentition in holoprosencephaly, ranging from cyclopia to more frequently hypotelarism, and when looking at the globes, anophthalmia or microphthalmia. With regard to the nose, complete arrhynia, absent nose and nasal cavity, flattening of the nose, a single nostril, or narrowing of the anterior nasal aperture known as piriform aperture stenosis. And these anomalies can be associated then with a single solitary central mega incisor tooth, which is characteristic. If you see piriform aperture stenosis and the dental anomaly, look upstream for holoprosencephaly, but it's not invariably present. Conversely, if you see holoprosencephaly, look south for maxillofacial abnormalities. Here's an example on fetal MR: the normal U-shaped palate, the abnormal triangular palate, single solitary mega incisor, and the rare anomaly known as piriform aperture stenosis, or narrowing of the anterior nasal aperture, much less common than choanal atresia. Now, when it comes to holoprosencephaly and piriform aperture stenosis, etc., these conditions are associated strongly with genetic mutations involving sonic hedgehog and interrelated signaling pathways, and these can be attributed to teratogenic effects or genetic causes. Now, here is an example of a median cleft lip and palate, but in this patient the eyes were wide apart. And so, having talked about this median cleft with hypotelarism as a marker for holoprosencephaly, if you should see the rare median cleft with hypertelarism, look north for cephaloceles and a genesis of the corpus callosum. This is an example of a large median cleft with a large frontonasal cephalocele and hypertelarism and deformity of the nose. Much more frequently, we see paramedian cleft lip and or palate. These clefts are now located between the central incisor teeth and the canine teeth, and typically the lateral incisor tooth on the side of the cleft is absent. Look for associated deviation of the nasal septum, asymmetry of the floor of the nasal cavity, and if the cleft goes back into the hard palate, then look for air-containing oronasal fistula. This is an example of bilateral cleft lip with a slightly protruding premaxillary segment and a defined incomplete cleft of the alveolar margin. But in this patient also there is abnormality affecting the nasal cavity, which is not well seen on one side, and if you look carefully, you should be able to see the inner ear structures at this stage, and they look abnormal with a very small vestibule and absent semicircular canals. So this patient has a well-known underlying syndrome. Charge syndrome, again with well-characterized underlying genetic mutation. In these patients, a major criterion is atresia choanai. Interestingly, choanal atresia is not present in the majority of patients. Most commonly, the craniofacial anomaly that you'll see is a cleft lip and palate. And so if I see a patient where we're told on fetal imaging there are heart defects, cleft lip and palate, then I look very carefully at the ear. Patients with charge syndrome invariably have very characteristic inner ear anomalies. Much less frequently, we will encounter facial clefts that are away from the typical involvement of lip and palate. And for these we use the Tessier classification, and they are assigned numbers according to their distribution. Interestingly, the more medial clefts have more severe cutaneous involvement, less pronounced bone involvement, although obviously bone and skin can all be involved, whereas the more lateral clefts have very more prominent bone involvement and less obvious overlying skin involvement. An example of Tessier 7 cleft is a defect in the zygomatic arches that are a highlight of Treacher Collins syndrome and hemifacial microsomia. Now look at this patient. This is an example of a tessier cleft, a rare cleft involving the nose. The nose is malformed and flattened. There's hypertelorism, epibulbar lipodermoids, and a large area of anterior skull defect, as you can see here in this unusual craniofacial disorder. Nasal anomalies, again, a whole variety of associated etiologies and disorders. So let's look at some of these. This is an example of complete absence of the nose and nasal cavity with microphthalmia. And in this patient, there is pronounced mid-face hypoplasia. The nose is flattened. This patient also had abnormal feet. And postnatally, look at these stippled epiphyses, which are typical of chondrodysplasia punctata, also a cause of craniofacial anomaly. Here's a potpourri of craniofacial disorders with nasal anomalies. In the first, there's hypertelorism, marked anomaly involving the skull, the nose. There's cleft lip and palate. This can be associated with a defect as seen in the earlier patient, as well as sometimes craniosynostosis, and this is frontonasal dysplasia. How about this patient? Well, this is Bosma syndrome. It's very unusual. The nose and nasal cavity are absent, and there's microphthalmos. And this middle patient, once in a lifetime, mandibular duplication anomaly, partial maxillary duplication, wide set eyes, and this abnormal fatty hamartomatous mass in the midline that resulted in a cleft palate, and this patient also had duplication of the pituitary gland. This rare entity is known as diprosopus. Finally, moving on to craniosynostosis. This is defined as primary due to premature closure of cranial sutures with resultant deformity that can involve single or multiple sutures and be syndromic or non-syndromic in etiology. But sutures can also close prematurely in response to other abnormalities as outlined. Primary craniosynostosis, majority are non-syndromic, but you'll be thinking of a causative mutation in those who have coronal craniosynostosis, particularly if it is bilateral, and for these children, genetic testing is recommended. Remember, the cranial sutures follow predictable timing and patterns of closure from the neonate through childhood, and it's important to be aware of these. And also, abnormal head shapes can be seen without necessarily incriminating craniosynostosis. Dolichocephaly in extreme preemies, deformational or positional plagiocephaly, extremely common, and plagiocephaly in association with osteogenesis imperfecta. But should you see pronounced dolichocephaly or scaphocephaly, then look carefully for sagittal synostosis, as in this patient here. Look for the internal ridging and the fused suture, as seen. The midline pointing and hypotelorism, as seen with metopic craniosynostosis. Plagiocephaly due to unilateral coronal craniosynostosis, or unilateral lambdoid craniosynostosis, much less frequently encountered than deformational plagiocephaly, and then bilateral coronal craniosynostosis in association with midface hypoplasia, shallow orbits with exorbitism, and this is a feature of a variety of syndromes. In this patient, the clue here is the widened metopic and sagittal suture. Taricephaly or towering head due to multi-sutural synostosis, and clover leaf deformity, again due to multi-sutural synostosis with here prominent convolutional impressions. Prenatal imaging, look for frontal bossing, hypotelorism, a very early sign, shortening of the anterior cranial fossa, coronal ridging over here, and in this case, a clover leaf deformity with ventriculomegaly, effaced extraaxial spaces, cerebellar tonsillar herniation, as seen in syndromes such as thanatophoric dwarfism, Apert, Cruzon, and Pfeiffer syndrome. With regard to syndromic craniosynostosis, the underlying genetic mutations have been well characterized, And this condition involves those signaling immature cells to become bone cells during embryonic development, with mutations in specific parts of fibroblast growth factor genes that alter the protein to prolong signaling and in turn promoting premature fusion of these bones. A whole variety of syndromes are well characterized with considerable phenotypic variability. This is an example of a fetus with frontal bossing, shortened anterior cranial fossa, pronounced hypertelorism. There is cleft palate, and there's agenesis of the corpus callosum. Postnatally, look at the polysyndactyly in this case of Apert syndrome, and there is a telltale very widened metopic and sagittal suture. In Apert syndrome, in addition to craniosynostosis and midface hypoplasia, you also see nasal cavity stenosis. These patients often have respiratory obstruction due to the marked midface hypoplasia. Chiari-1 deformation can occur, ventriculomegaly, which may be actually attributable to venous hypertension from associated venous anomalies, as well as other organ system abnormalities. Many patients with craniosynostosis, their clinical course is rather complicated. They have surgery during infancy to release the craniosynostosis. The timing is really rather complicated because of the venous hypertension. They tend to bleed, so surgery is deferred to a point when they can tolerate potential blood loss. And then post-operatively, we are often asked to reassess sutures, to assess for preoperative analysis prior to midface advancement, and then these children are at risk of having postoperative complications such as CSF leaks and cephaloceles. We also follow up ventriculomegaly and tonsillar herniation with judicious use of low-dose CT and various MR techniques. So in closing off, what does the future hold for craniofacial imaging? Well, it is my hope that we will increasingly use artificial intelligence to help classify images and predict the genotype, and also by clustering patients by phenotype, and then we can connect and diagnose rare conditions. Also, if we incorporate the use of gene panel and whole exome sequencing and follow-up cases to link back the genetic results with what we saw in imaging, we can learn a whole amount, and with these techniques then aim to improve patient care and, very importantly, for fetal imaging, improve parental counseling. Thank you so much for your time and attention.
The last lecture of this session will be given by Dr. Tabassum Kennedy, Neuroradiology Division Chief, Associate Professor, School of Medicine and Public Health, University of Wisconsin Medicine. Her topic is head and neck manifestations of systemic disease.
I'd like to thank the ASHNR for giving me the opportunity to participate in this year's annual meeting. The topic of my talk today is head and neck manifestations of systemic disease. By the end of my talk, I'm hoping that you'll be able to recognize how systemic diseases can involve the head and neck. Many multisystem disease processes have manifestations within the head and neck, and patients may present with the head and neck manifestations of their systemic condition, and oftentimes it presents masquerading as an infection. Anticipating these expected patterns of disease will allow us as head and neck radiologists to look for some additional clues, looking for that second, third, and fourth finding in their imaging to help aid in their diagnosis. So the format of the talk today is case-based. So our first patient is a 39-year-old who presents with a concern for mastoiditis. Over the past 2 months, he describes decreased hearing, leptotalgia, and tinnitus. 2 weeks prior to presentation, he experiences bloody otorrhea, and he now presents to the ER with escalating symptoms. He has reports of several episodes of blood-tinged sputum as well as shortness of breath, and he has also had multiple courses of antibiotics without any improvement in his symptoms. So because the ER was worried about complications related to mastoiditis, they ordered a CT examination of the temporal bone. And here in this example, we can see that there's complete opacification of the left mastoid air cells as well as within the middle ear cavity. We can see that the osseous septations within the mastoid air cells are intact, and we don't have any evidence of bony erosion. Now, because the patient had persistent symptoms of left mastoid and middle ear effusions, our attention then goes to the left nasopharynx to look for a potential obstructing lesion. And here on these soft tissue windows, we can see that there's asymmetric soft tissue thickening within that left nasopharynx. We can also see some additional findings within the left nasal cavity. There's this complete opacification within the left sinonasal cavity. Now, because the patient also had some airway findings on physical exam, they subsequently got a CT examination of the neck, as well as some additional imaging of the lungs. When we take a look at the airway, we see that there is circumferential soft tissue thickening of the subglottic larynx, which was confirmed on endoscopy, and subtle soft tissue thickening around the carotid arteries. When we take a look at the lungs, we also notice that there are multifocal areas of consolidation, and notice that the abnormality in the left lower lobe also has cavitation. For a differential diagnosis, the first thing that they were worried about, certainly, was malignant otitis externa. So with malignant otitis externa, we expect to see disease in the external auditory canal with involvement of the skull base, as we see in this example, and soft tissue thickening in the nasopharyngeal region. They also considered septic thrombophlebitis because they thought the patient had complications related to mastoiditis with concomitant pulmonary infection. We see in this example, however, that you would expect to see venous thrombosis, which was not present in our case. Sarcoidosis is definitely an additional consideration, particularly because of the airway involvement and the lung involvement. So here in this patient, we can see that there's circumferential soft tissue thickening involving the trachea, as well as hilar adenopathy and small micronodules within a perilymphatic distribution. Amyloid also involves the airway. As we can see in this example, there is circumferential soft tissue thickening within the trachea. The final condition on our differential diagnosis was granulomatosis with polyangiitis. We favored GPA because of the constellation of imaging findings, particularly those found in the lungs. Our patient presented with their otologic manifestations of disease, which is less common than the more typical presentation of sinonasal involvement. Granulomatosis with polyangiitis is a small vessel vasculitis that's characterized by necrosis, granulomatous inflammation, and vasculitis that predominantly involves the upper and lower respiratory tracts as well as the kidneys. Diagnosis is confirmed by serology and histologic analysis as was performed in this patient. Because the upper respiratory tract is primarily involved, their classic otorhinologic manifestations may be their presenting symptoms. Our second patient is a 15-year-old girl who presents with a concern for orbital cellulitis. She has a history of chronic sinusitis and epistaxis. So because they were worried about orbital cellulitis, they ordered a CT examination of the orbits with contrast to look for complications. So in this patient, we can see that there's bilateral soft tissue thickening of the lacrimal glands. We also can see that there's opacification within the right anterior ethmoid air cells. Looking at the adjacent soft tissues, we can see that there's some subtle inflammatory fat stranding, but we don't have any evidence of intraorbital abscess, at least on this one single image. Looking at a coronal and sagittal view, we can see similar findings on our coronal projection, where we have thickening and abnormal enlargement of the lacrimal glands. We also can see an additional finding here. We see that there's some subtle thickening of the pituitary gland. Because of that finding, the patient went on to get an MRI for further characterization. So on MR, we can see that there's abnormal soft tissue thickening of the lacrimal glands, as well as opacification of the sinonasal cavity. We don't have any evidence of complication, so there's no abscess intracranially or within the orbits itself. We can see that there's soft tissue thickening of the pituitary gland that looks like it's confined to the pituitary itself. So our differential diagnosis for enlargement of the lacrimal glands certainly is going to include conditions like lymphoma. And in lymphoma, we can see bilateral involvement. We tend to not see associated inflammatory change like we do see in our patient presenting today. We should also consider some additional inflammatory conditions, including IgG4-related disease, amyloid, sarcoid, as well as granulomatosis with polyangiitis. This patient went on to have subsequent imaging, and we can see that there are bilateral low attenuation masses within the parotid glands, as well as laryngeal soft tissue thickening. Looking at the lungs, we can see that this patient has multiple pulmonary nodules, some of which have cavitation. There's also soft tissue thickening around the distal trachea. This patient also had biopsy-proven granulomatosis with polyangiitis. While this patient came to clinical attention because of their lacrimal gland involvement, sinonasal disease was certainly there at presentation. We can see that over time, the progressive erosion of the turbinates and the nasal septum, which is a complication of this condition. Our next patient is a 50-year-old woman presenting with bitemporal hemianopsia. Because of this classic pattern of visual field loss, a compressive abnormality was suspected at the level of the optic chiasm, which was evaluated with a dedicated pituitary protocol MR examination. On MR, we can see that there's marked thickening of the pituitary gland and of the infundibulum, which extends up to cause mass effect on the optic chiasm and the optic tracts, as well as some edema within the hypothalamus. We also note this additional finding. We can see that there's failure of CSF suppression within the sulci along the frontal lobes, which corresponds to some subtle enhancement on our post-contrast sequence. Now, if we are considering our differential diagnosis for disease processes that involve the pituitary gland, we of course want to think about an adenoma and a craniopharyngioma. For lesions that involve the infundibulum, we want to consider lymphocytic hypophysitis as well as eosinophilic granuloma in the younger demographic. Now, because we have this additional finding of leptomeningeal enhancement and failure of flare suppression, we want to think about some additional disease processes, including sarcoidosis, germinoma, and lymphoma or metastatic disease. Because of the intracranial findings, a chest CT was recommended, and we can see several findings. Bilateral hilar adenopathy, as well as several micronodules within the lower lobes, suggesting the diagnosis of sarcoidosis. A workup subsequently included a number of lab tests which showed ACE levels at the upper limits of normal in the serum and CSF. Biopsy of the nodes ultimately showed non-caseating granulomas, indicating a diagnosis of sarcoidosis. The patient was treated with steroids, and we can see 1 year later that the disease process within the pituitary and infundibulum, as well as along the leptomeninges, has significantly improved. Sarcoidosis is an idiopathic granulomatous condition characterized by non-caseating granulomas. Pulmonary findings are seen most often, so if you're considering a diagnosis of sarcoidosis in your patient, recommend a chest CT to evaluate for pulmonary nodules within a perilymphatic distribution, as well as hilar and mediastinal adenopathy. When sarcoidosis involves the head and neck, it can occur in any one of these sites. So if you see an atypical or unusual inflammatory mass within any one of these areas, consider sarcoidosis on your differential. Our next patient is a 51-year-old male who initially presented for evaluation for a sore throat. He was found to have a T2N2 squamous cell cancer of his left oropharynx. On his staging CT examination, we can see that there's asymmetric enlargement of the left palatine tonsil associated with this large level 2 nodal mass. On his staging CT study, we can see that there's also an additional finding. We see bilateral enlarged hilar lymph nodes, as well as enlarged mediastinal lymph nodes. So is this disease process within the chest related to metastatic disease? That's really one question that we have to consider in this patient. This patient was further evaluated with PET imaging, and we can see hypermetabolic activity within the left level 2 nodal mass, as well as hypermetabolic activity within the palatine tonsils. We also can see that the disease process within the chest is also hypermetabolic. This patient had biopsy-proven squamous cell cancer within the palatine tonsil and level 2 nodal disease, and sarcoidosis within the chest. Now, the imaging finding that was characteristic of sarcoidosis here is the bilateral hilar adenopathy. So this is an important pitfall to recognize in patients that are being staged for head and neck cancer. A second companion case in this category is a 52-year-old who's presenting with a history of breast cancer, and we're asked to evaluate for intracranial metastatic disease. The patient did not have any evidence of intracranial metastatic disease, but we do see the subtle lesion within the right lateral orbital wall, which was initially overlooked at this imaging study. So at 2 years, we can see that this lesion has certainly increased in size, now replacing really much of that right lateral orbital wall. on the bone scan, we can see that it is hot, and on CT, we can see that the lesion is predominantly characterized by lucency or a lytic appearance. The lesion increases in size at 5 years and further increases in size at 6 years. Now, our differential diagnosis is certainly going to include metastatic disease because of this patient's known history of breast cancer. That was our primary concern, and the lesion was biopsied at the 2-year mark. We also want to think about other conditions like fibrous dysplasia, and in fibrous dysplasia it tends to have more of this ground glass appearance, although there certainly can be lytic regions associated with fibrous dysplasia. Sarcoid can also have lytic lesions within the bone, and when it has been described in the literature, oftentimes these areas of lucency in terms of distribution more often involve the digits, and it has been described as a lace-like kind of appearance. So this patient's lesion was biopsied at the 2-year mark and at the 5-year mark because of this interval growth, and it was pathologically proven to represent granulomatous infection related to sarcoidosis. Now, sarcoidosis, when it involves the bone, it is fairly uncommon, and it has been described as occurring in 1 to 13% of patients. Our fourth patient is a 49-year-old who's presenting with diplopia. So we can see on this MR examination that we have abnormal soft tissue thickening involving the inferior rectus, the medial and lateral rectus muscles, with this amorphous soft tissue enhancement and low signal on T1. Now we can see that this finding is fairly unilateral in appearance, with the left extraocular muscles appearing relatively normal. On this axial post-contrast image, we can see that there's also some involvement of the cranial nerves as they're traveling through the supraorbital fissure. So our differential diagnosis for this process is fairly broad, and it includes all of our favorite inflammatory conditions, as well as lymphoma. We can see that in these various imaging examples that there are a lot of overlapping imaging features, making it really challenging to differentiate between these entities just on CT or MR imaging of the head and neck alone. One can try to look at additional clues outside the head and neck, but in this patient, no additional manifestations of disease were identified. So ultimately, our patient was biopsied and it was positive for IgG4-related disease. The patient comes back to the hospital 2 years later, now with right leg edema. On this abdomen pelvis CT examination, we can see that there's this amorphous soft tissue process that is occurring within the presacral space. This region was also biopsied, and it was a second site of IgG4-related disease. So IgG4-related disease is relatively recent, and that it was discovered back in 2003. And this initially was kind of captured under the umbrella of idiopathic orbital inflammatory syndrome for us in the head and neck. But in 2003, it was recognized as its own separate pathologic entity. This results from tumefactive lesions that are infiltrate-rich in IgG4-related plasma cells, and when it involves the head and neck, it typically involves the meninges, the periorbital soft tissues, including the cranial nerves, salivary glands, thyroid, and lymph nodes. Outside the head and neck, and this is really where that looking for these additional clues may help to aid in the diagnosis, to eliminate or to hone in on our differential. If we have involvement of a similar inflammatory process within the biliary tree, the kidneys, the lungs, the aorta, pancreas, breast, prostate, or retroperitoneum, we would potentially want to think about IgG4 as the favored diagnosis. Our next case is a 71-year-old male who's presenting with chronic sinusitis. He has a new presentation of bilateral apoptosis and a rash described as erythematous with purpuric papules. While this example is from the literature, by report, the rash is very similar in appearance. So we can see on this CT example, we have complete opacification of the bilateral sinonasal cavity, including the ethmoid air cells, the nasal cavity, as well as the maxillary sinuses. Looking for complications of sinusitis, we don't have any evidence of intraorbital extension. However, we do notice that the extraocular muscles are much bigger on today's scan, especially when we compare it to a study that was obtained 2 years prior. So on MR, we can see similar findings in that we have thickening and enhancement of the extraocular muscles in a bilateral and symmetric distribution. We also have the findings within the sinonasal cavity illustrated by opacification, as well as mixed signal on our T2 and our post-contrast sequences. So based on the bilateral and symmetric distribution of extraocular muscle involvement, our primary differential diagnosis is going to include thyroid eye disease. So in this example, we can see markedly enlarged extraocular muscles that primarily involve the inferior and medial rectus muscles to a lesser extent when compared to the lateral rectus muscles. Idiopathic orbital inflammatory syndrome is also another condition that can involve extraocular muscle enlargement, and in this patient we can see that there's asymmetric enlargement, and it tends to involve that myotendinous junction, which is typically spared with thyroid eye disease. Lymphoma can also involve the extraocular muscles primarily, and it tends to be asymmetric in terms of its distribution. Congestive orbitopathy can result from a cavernous sinus fistula or cavernous sinus thrombosis related to venous or arterial congestion, resulting in enlargement of the extraocular muscles, like we see in this example. Granulomatosis with polyangiitis can also involve the extraocular muscles, as we've seen in a couple of other examples today, as well as IgG4-related disease. This patient had markedly elevated eosinophils, which helped the rheumatologist figure out the diagnosis in this patient. So based on the presence of the underlying rash, the sinonasal disease, as well as the extraocular muscle enlargement, our rheumatologic colleagues were favoring a diagnosis of eosinophilic granulomatosis with polyangiitis, formerly known as Scherg-Strauss syndrome. This was biopsied, and this was consistent with EGPA. So this is a rare systemic vasculitis, which is characterized by asthma, allergy symptoms, as well as eosinophilia, with necrotizing vasculitis involving small and medium-sized vessels. Typical findings in the head and neck, as we see in this example, are sinus disease as well as orbital involvement, and the treatment is with corticosteroids. Our next case is a 54-year-old who's presenting with right submandibular fullness. The patient also has a history of familial polyposis and has a recent diagnosis of colorectal cancer. So on these CT images of the abdomen, we can see the colorectal cancer on this top image, as well as an additional polyp within the right cecum. The patient had a CT examination of the maxillofacial region, and we can see this cauliflower-shaped excrescence arising from the right aspect of the mandibular angle. When we look at the rest of the sinuses to look for some additional clues, we can see multiple osteomas within the frontal sinuses as well as within the ethmoid. So when we have a patient that has multiple osteomas, in addition to this history of familial polyposis, we want to consider a diagnosis of Gardner syndrome. Gardner syndrome is an autosomal dominant subtype of familial adenomatous polyposis, and what we see in the head and neck are multiple osteomas, which typically can occur within the sinuses or along the mandible. We also can see papillary thyroid cancer, which is something that I didn't realize was associated with Gardner syndrome, and so these patients will also get surveillance of their thyroid with ultrasound. Extracolonic features often precede their colonic polyps, so we may be able to suggest the diagnosis based on that finding of multiple osteomas within their paranasal sinuses. Our next case is a 15-year-old who presents with a known history of shunted hydrocephalus. The patient had previously resected posterior fossa P-net tumor and was undergoing active dental surveillance. So on this MR examination of their occipital lobes as well as the top of their cerebellum, we can see this was their P-net lesion that was a subtle enhancing lesion along the superior aspect of their vermis. Looking at the Panorex examination in this child, we can see that we have a lucent lesion that's associated with this developing left mandibular molar tooth. 2 years later, we can see that we have enlargement of that lucency adjacent to that molar tooth, in addition to additional lesions involving and adjacent to the right maxillary molar teeth, as well as a newly developed lesion adjacent to their right mandibular molar tooth. This lesion on the right, we can see, even results in this kind of floating tooth appearance of that right maxillary molar. So on CT, we can see bilateral expansile lesions that are odontogenic in origin that involve the maxilla as well as the mandible, although they are not profiled on these two images. We can see that this lesion on the right is really extended and expanded into the right maxillary sinus, such that it is displacing that right maxillary molar tooth. So our differential diagnosis is going to include odontogenic lesions, including a dentigerous cyst, which is a pericoronal lucency associated with the crown of an unerupted tooth. We also want to think about other conditions, including Langerhans cell histiocytosis, which is typically described as a lytic lesion associated with the bone, and it can result in periosteal reaction and a floating tooth appearance. We also want to think about keratocystic odontogenic tumors, which often occur within the mandible or the maxilla adjacent to the canine and premolar teeth. So this patient had multiple lytic lesions, expansile, involving the maxilla and mandible. These are examples of keratocystic odontogenic tumors in association with Gorlin syndrome or basal cell nevus syndrome. This condition is autosomal dominant and it's linked to the PTCH gene on chromosome 9. And these patients have multiple findings. So they're being evaluated for basal cell cancers. Their head and neck manifestations include keratocystic odontogenic tumors as well as craniofacial abnormalities. Their neuromanifestations, they will often have dural calcifications, as we can see in this child, as well as a PNET or medulloblastomas. Abdominal findings include calcified ovarian fibromas, and then they will have a characteristic palmar pit on their palms. Today we focused on 4 systemic conditions that can present with head and neck manifestations of their disease. We reviewed some common and uncommon patterns of disease and considered the differential diagnosis for each site. We also discussed how the lungs can be particularly helpful in facilitating a diagnosis of GPA and sarcoid, and reviewed how identifying inflammatory disease below the level of the diaphragm may help with the diagnosis of IgG4. With all of these conditions, though, biopsy is often needed to confirm the diagnosis. We also reviewed 2 neoplastic syndromes with head and neck manifestations that fall within the Aunt Minnie umbrella. Thank you so much for your attention.
This ends the session. I would like to thank all the speakers on behalf of Dr. MJ and me. Thank you.